Welcome to the Professional Issues module of this series. This area on the exam accounts for 14 questions, which really isn't that big. It's about 9% of the total questions that'll count towards the score. However, I have to be honest, I think this is one of the areas that a lot of people may struggle with the most when it comes to the material. This is a lot of material that a lot of nurses may not do in their everyday practice, and it might be quite unfamiliar. So this will probably be a little bit of a longer module to watch, and one that you may need to do a lot of extra studying, because I'm going to guess I may touch on a lot of topics and introduce them that you might say, wow, I don't really know a lot about that. And that would be a good trigger to go study more. So that's going to be my guess. But as we've always been doing, let's start with a challenge question. So a medically competent patient chooses to leave the emergency department without receiving the recommended medical treatment. Although the risks of leaving without medical treatment are reviewed with the patient, no attempts are made to stop the patient from leaving. The basis for this action is based on A, just culture, B, patient safety, C, express consent, or D, the ethical principle of beneficence. Do you see what I mean? These topics are a little bit out there, right? They're not easy to grab onto like an MI or a stroke. These are things you may not do every day. What is professional issues? Well, professional issues really describes topics that are not disease related. So we're not going to be talking about diseases in this module. We're going to be talking about the actual provision of care. It's going to be things like ethics, like consent, like legal issues, like quality improvement. Those are what fits into the topic of professional issues. So let's get started with the first topic, which is just culture. You know, just culture has an interesting history. I look back when I started nursing a number of years ago. When a medical mistake was made, it was scary because you would figure I'm going to be in trouble because we just made a medicine error, and I'm going to be in a lot of trouble for it. And truly, that's what you thought. You were scared when you made a mistake of the trouble you were going to be in. Well, kind of in the late 90s or early 2000s, we begin to swing, and the focus turned to looking at systems and saying, you know what? It's not the individual who's making the error. It's the fact that our system doesn't work, and that when an error is made, it's because there's a weakness in the system, and we shouldn't be blaming individuals for the mistakes. We should be fixing the system. And this was a really big step in the right direction. However, I think we swung a little too far for a while, in where people were thinking that they couldn't get in trouble for anything because if a mistake happened, then everybody would fix the system and ignore them. And sometimes they did things that really were their fault. So just culture brings us to kind of a center point between the two. And with a just culture, we're balancing mistakes between looking at the system and saying, wow, is it that the system is flawed and we need to fix it? Or is it that the individual working within the system is not following the system, and that's the reason for the error? And so sometimes we need to fix the system, but sometimes we need to address the person. And just culture is the way that we look at mistakes and try to balance these two. Now, when you look at a just culture algorithm, we kind of divide medical mistakes into three different categories, and they are human error, at-risk behavior, and reckless behavior. Now, human error, the first one we'll talk about, is where a mistake happens, but it's completely inadvertent. It could be a slip or a lapse. It could be a mistake related to poor processes. It could be a lack of education about something. It could be environmental. But basically with a human error, what we're saying is, you know, the system isn't perfect. Maybe somebody grabbed the wrong medication in a code and gave the wrong medication. Or maybe the wrong dose was said and the wrong dose was pushed, right? Nobody intended for that mistake to happen. It was completely inadvertent. It happened in the busyness of resuscitation. And maybe what we need to say is we need a better system. Maybe we need a pharmacist in the room during the code to make sure that the doses that are verbalized are accurate, or something like that. So we are still looking at a system type of a fix with a human error. So your human errors are managed by fixing the processes, not the human being. Okay? So basically, when a mistake happens and it's deemed to be human error, something that's really related to the system, and we can fix it in the system, then the response to the employee involved is to console them and to say, I'm sorry that you were in this system that really set you up for this error. Now, the second type of mistake is called at-risk behavior. Now, in at-risk behavior, the person who makes the mistake makes a choice, and they know that the choice might have a negative consequence, but they believe that the choice is the easier route to take or the appropriate route to take. So sometimes there's a good system in place, but the individual has to work outside the system, either because it's necessity or because they believe it's better. So again, they're not intending to hurt anybody. They're not intending to make a mistake, but they may be acting outside the system. So if we try to think of a good example of this, let's say that again, we're working in a code, and the nurse doesn't check the patient's allergies in advance. I'm not sure this is a good example, but I'm going to use it anyway. They don't check the allergies in advance, right? Because they want to push the drug quickly, knowing that this is a resuscitation. So they know they should be checking allergies first, but they choose not to do it because it's an emergency situation and they believe the patient needs it, and they end up pushing a drug that the patient's allergic to. That's at-risk behavior, because there's a system in place where the allergies are listed and the nurse is supposed to check it before they give the drug. But the nurse didn't check the allergies, but they failed to check the allergies not because they meant to harm the patient or they were intentional. Their thought was, I can't do it now because this is an emergency situation and the patient needs a drug and I'm going to bypass it. And bypassing it ended up having a bad consequence. So how do we manage at-risk behavior where the system works, but the person worked outside the system with good intentions? Well, number one, we need to remove incentives for at-risk behavior. And we need to look at the system. Maybe the system would say, hey, there's a better place to put the allergies that's easier to look at, right? So we could fix that, number one. But number two, we maybe need to say, well, is there certain incentives that cause the nurse to take that behavior? Or could we create incentives that makes the nurse want to do that behavior in the future? Do we need to find a way to increase situational awareness? So when an individual is caught in at-risk behavior, when I say caught, that's a bad word, but when they're involved in at-risk behavior, our response is to coach them. So it's not to punish them, but it's to say, hey, this happened, and I think that, in the future we can address this better. We're going to look at the systems, but you need to think about, this action. So it's a coaching. Now, the third type of mistake in just culture is reckless behavior. And that is just exactly what the name implies. The employee intentionally does something knowing full well it could have a bad outcome. The system is in place, the system works, the employee works outside the system, they know that the outcome's going to be bad, but they do it anyway. I think of an example I have when I was an ER director. One of my employees was involved in a violent patient episode. A patient became very violent, and they were having troubles restraining it, and the patient was hitting people, and out of anger, my employee kicked the patient in the face. I'm afraid to say it. It's horrible to say it, but it happened. And injured the patient, right? And that's a horrible mistake. But you know what? It's hard to, in any way, shape, or form, say that's anything but reckless behavior, right? I mean, we know that there are ways to manage violence in the workplace, and certainly injuring a patient would not be one. So we can look at the system there, and we may be able to find better ways to keep the staff safe, and I don't want to minimize that. There was certainly things we could do. But overall, that was just simple reckless behavior, and when you have reckless behavior that results in injury where the employee intentionally worked outside the system knowing the outcome was going to be bad and they did it anyway, they'll need remedial action or punitive action, and the response of the employee is to punish them. So those are your three types of errors. There's human error, where it's a system problem and the individual got caught in it. There's at-risk behavior, where the system is in place, but the employee chose to act out of it in good faith, believing they were doing the right thing. And then there's just reckless behavior, where they act outside of the system in a way that is obvious it's going to cause patient harm. And you either console, coach, or punish.